Good afternoon, everybody. Welcome to this webinar on the European Public Health Week on the country visits. I see that there are still people dropping in, so we will start this webinar in 1 minute. All right, I see that many people have joined this webinar. Thank you so much for joining, and let's start. So welcome to this UvA Public Health Week event that is organized by Cienzano, which is the Belgian Public Health Institute. And at Cienzano, we are participating and we are coordinating many European projects. In two of these projects, that is the PHIRI project and the TEHDAS project, and I will explain these abbreviations later, we are conducting country visits, so semi-structured interviews with key stakeholders in the national health information systems in Europe in order to map their health information systems. Both of the projects are using the same methodology, but have a different aim. And in this 1-hour webinar, we would like to present to you the methodology and provide you already with some preliminary results of both of the projects. We will record this meeting. And if you have any questions, please drop them in the chat and we will give you the stage afterwards after we have finalized the presentations on the preliminary results. Next slide, please. So on the agenda today, so I will give a short introduction about both of the two projects that I've just mentioned. We will discuss the methodology that we've been using in both of the projects. Then we will go to some preliminary results of the PHIRI project, the TEHDAS project. We will announce a more general meeting on this topic, more in depth, at the end of the next month. And at the end, we have some time for a Q&A. Next slide, please. So first, we start the introduction of the two projects. These two projects are both two projects that we're both working on at Cienzano. So the Population Health Information Research Infrastructure, or we call it PHIRI for short, is a project that is coordinated by Cienzano. It's already been running for 1.5 years. And it's a project that is funded by DGRTD, covering 30 European countries. The TEHDAS project, that is short for Towards the European Health Data Space, is a joint action that is coordinated by the Finnish Innovation Fund Sitra and has started a few months later, is running for 2.5 years and is covering 25 European countries. So both of these two European projects cover a large amount of the European countries. Next slide, please. So what are the different aims of the country visits that are performed in both of the different projects? So for PHIRI, we are focusing on mapping the health information system that monitors the effects of COVID-19 on population health. So all the data flows, all the information flows with regard to COVID-19 within the health information system. These country visits started December last year and will be running for 14 months. In the TEHDAS project, they also do a mapping of the national health information systems, but focusing on mapping the state of play of the national health data management developments in relation to the future European health data space. You might know that about 2 weeks ago, the new legislation for the European health data space is presented, and the TEHDAS project is now mapping the national health data management developments to see how ready the countries are to implement this future European health data space. This project is also running for 12 months and also started in December 2021. So both of these projects are currently up and running. Next slide, please. So although the aim of the both projects is different, they're applying the same methodology. So we will be doing semi-structured interviews in both projects with key stakeholders in the National Health Information System. So what are these National Health Information key stakeholders? That's, for example, the Ministry of Health, the National Statistical Office, other agencies that are doing in collecting information with regards to health data or are governing health data. In most of the country visits, we are performing 6 or 7 within PHIRI, and in TEHDAS more up to 15 interviews. What tool are we using? So the WHO has provided us with a tool that is publicly available to strengthen health information systems. And both of the projects use this very same tool, although slightly adapted to their purpose. Both of the projects are covering data sources, data quality and analysis, reporting, data governance, resources, knowledge translation, and of course, for PHIRI, we tailor this specifically to COVID-19. And for TEHDAS, we tailor this specifically to the preparedness for the European health data space. Next slide, please. So we have adapted this very tool to fit its purpose. And we have in both projects different roles. So there is the assessor that acts as an independent assessor to create engagement and carry out the assessment. So the desk report that has been to be prepared before the interviews, the interviewing, and the summary of the outcomes. And within each assessed country, there is a contact person that is a national liaison during the assessments, providing the assessors with the relevant documentation, help the assessors to identify key stakeholders and plans the interviews. In PHIRI, we have also a system where there's an observer to provide some support during the assessment, because this observer has a lot of previous experience and can help us in identify overarching outcomes across all the different assessments. Next slide, please. So within PHIRI, we will conducting country visits in 10 different countries. And there are 10 assessments scheduled so far. You see that we have a very nice geographical distribution across Europe. And then for TEHDAS, that is mapped in the next slide, you see that there are 12 assessment schedules of the countries that are listed here. For now, we have an overlap of 2 countries that we visited so far. That is Ireland and Portugal. But in the future, we'll be having more overlapping countries, such as the Netherlands and Belgium. I would now like to ask my colleague Linda to provide us with some more information about the methodology of the country visits. Thank you.
Yes, thank you very much, Nienke. I hope you can hear me.
Very well.
Great. So like Nienke said, I will dive a little bit deeper into the methodology aspect, which is shared by the two project, the country visits that we are implementing within St. Sano. This first slide shows a brief presentation of the different steps that we're taking. So we're starting with a preparation, which is including a preparatory report and together with the stakeholders, with the contact person that Nienke mentioned previously to identify the different stakeholders. Then we have the actual country visit, which is the interviews. Then we have debriefing sessions and the final reporting. I will now go into each of them a bit more in detail. So starting with the first one, which is the preparatory desk review. This is, like I said, done in collaboration with the contact in the certain country that we are visiting. So we have the set of assessors that Nienke mentioned, and we have the country contact. Together, we try to already get an initial idea of what the situation is in the country. So, for example, the country contact provides us with some documents and information that then the assessors can read and then have some insight into what the health information look like, what the different management processes that are already taking place in the countries look like. This also then already gives us a little bit of an idea what are the different gaps, and maybe look into what more information we can try to ask about in these interviews. So very specifically in the case of the scope of PHIRI, the focus was more on the COVID data flows and the changes that happened in the health information system during the pandemic. And in the case of TEHDAS, the focus was really on the sharing and the secondary use of health data and what are the different preparations, whether it's politically or structurally, that are ongoing in the country with regards to the upcoming EHDS. The second aspect of the preparatory desk review is, together again with the contact person in the country, is to really identify who are the main stakeholders that we need to interview and to talk to be able to get this bigger picture for the different scopes that are mentioned for PHIRI and TEHDAS. So Ninka already gave a couple of examples, but the main ones that are for example shared between PHIRI and TEHDAS is the National Public Health Institute, the different relevant ministries, whether it's the Ministry of Health or the Ministry of Research. An important one also is the National Statistical Office, the health insurance companies, whether an IT or an e-health infrastructure exists in the country. In TEHDAS, for example, we also looked on whether there is a data permit authority or an information security committee in the country on how the secondary use and the access of data takes place. We also talked to different universities and university hospitals and additional hospital groups. In some cases, actually, we also talked to industry and data privacy committees as well. So together, this really gives us, we really try to bring in the point of view of the different stakeholders to get the overall picture of the status and mapping the country. The next step in the methodology is the actual country visit itself. So what we do is we use this tool that Nienke mentioned that is based on the assessment tool from the WHO, which we then adapt here and there to make it really fit better into the scope that we have and the specifics of the scope that we have. And we use that to talk to the different stakeholders. So these interviews can either be virtual or face-to-face, depending on the situation. You all know we've had a lot of ups and downs with the COVID, so whether it was not possible to do face-to-face, it turned out to be virtual. But in any way, we had a lot of opportunities to talk to different stakeholders, and it was always very insightful to talk to them. So in this country visit, what also takes place is that the group of stakeholders, so we're with a couple of people doing these country visits. After each interview, there are also debriefing sessions to look at the different information that was gathered in each interview and kind of assess what the situation is. And put together initial findings. This also helps us with looking into what we still need to dive in better in our next interviews, or what are the different topics that we need to focus on with the different stakeholders. This then gives you a better planning for the next days. So for example, in these interviews take place across a couple of days to be able to accommodate for the different stakeholders that we are talking to in the different countries. Yeah, that is then the part of the country visit. The next one is the debriefing meeting. So once we have finished all the interviews with the different stakeholders, we had our debriefing as assessors. We kind of brought together all the findings that we have gathered with regards to the different scopes that we have in each of the projects. We have we try to bring it together into a presentation, and we hold a stakeholder meeting, which is then organized really shortly after we finish the interviews. In this meeting, we bring together all the stakeholders that we have interviewed in the country, and it kind of brings the country visit to a conclusion and a closure. There we present the results, we deliver the initial findings, and this really brings an opportunity for the stakeholders from our experience so far together into one room. And sometimes some discussions come up with regards to what our initial findings are, and it really it could be quite interesting discussions. But it is also an opportunity for them to provide us with some feedback or comments with regards to the initial findings that we have presented. Another meeting that is still to be organized, this is mentioned by Nienke also in the beginning, is an open meeting, which we will also do together with the two projects. And that is a midterm meeting where we will go really into detail of the different countries that we have looked at so far and the main findings. And that is then open to all the stakeholders that have been interviewed, the countries that still to be interviewed, and open to the public as well. The next step is the reporting. So after we've had the debriefing meeting with the stakeholders, we had the discussions, they gave the comments and the feedback, we compile the results into a detailed report, which is then for the use of the country to look into what the situation is, if they want to take it further with next steps. And we also provide a one-pager which summarizes it into one fact sheet of what the situation is in the country with regards to the different topics that we talked about. The reports are obviously also sent for feedback sessions and loops with the stakeholders to make sure that whatever is published and reported is still correct and agreed upon also with the stakeholder. So that was very briefly the four steps that we use as the methodology, and that was very interesting. Actually, we have used this methodology in a previous project as well in a peer review format. We really found that it was a very the assessors as well as the countries found it in a very interesting and valuable experience to do these country visits for the countries themselves, but also for the assessors themselves. I could add some links to some publications that are related to the previous project, but this is also why we really thought it was very important to continue this in these different aspects and projects for the relevant scopes to provide the overview of the different countries and the situations. So to really summarize it, the added value for the assessed country for participating in such a country visit is, first of all, bringing the stakeholders together. In health information, we really sometimes see that in countries, there the stakeholders that are playing a really important role in this health information system don't know each other. And by doing this country visit, they really start talking together, especially the country contact who has to contact these different stakeholders, identify them, invite them for an interview. Many times this really helps to also create different connections, to understand what is happening in one's country. From experience, this was one of the great added values for the countries. Another important aspect is really that in one report, you're provided an overview with what the main stakeholders are, what their different roles are, what different data they use or data they share, and the different data management processes in the country. And this can then be used in the country for different aspects, whether for additional policy measures or research as well. One other thing that we look at in this country visit is also the needs and the expectations of the country, whether it's what happened during the COVID or whether it's with relation to the EHDS. So doing this country visit also it gives the opportunity to pinpoint different capacity building and training needs in the country. You can also look at it in a way that when an assessor from a different country participates and looks at what the situation is in the other country, they're learning as well what the situation is in the other country. So this is already an ongoing learning experience happening between the different assessed and assessor countries. That was also one of the experience that was really valued in previously. Specifically, no, sorry, go back. For PHIRI, the added value is really to identify the strengths and the weaknesses with regards to the data flow that were affected in COVID-19. This is also then complemented with a set of recommendations on how to be better prepared for future crises, for the resilience of the health information system. In the aspect of TEHDAS, it really provides us as TEHDAS as a project, but also as a commission, for example, insight into the current state of the health information systems in the country to really know what needs to be considered with regards to setting up this European health data space. So this brings in the map, the situation in the countries, and the awareness of the different stakeholders. So whether it is the countries, the member states, and the Commission as well. So all in all, you can see there's a lot to be learned from such a country visit. That's it from my side, and I will hand it back over to PHIRI to provide you with the preliminary results of the countries done so far. Thank you.
Thank you very much, Linda. Hi, good afternoon. I'm Marika. I'm a team member from Sensano working on the PHIRI project. As it was highlighted earlier, so PHIRI stands for the Population Health Information Research Infrastructure. So far in PHIRI, we have assessed 4 countries, Italy, Portugal, Ireland, and Malta, and we have interviewed different stakeholders, and the interviews took place virtually. We interviewed ministries for health, public health institutes, universities, researchers, and also statistics offices amongst other institutes. Next slide. So one of the aims of these country assessments is to identify the best practices so that they can be shared with other countries. In Italy, we saw that they had developed a strong vaccination information system before the COVID pandemic hit, and this facilitated the COVID vaccine rollout. We have seen a great effort by countries to set up systems and technological solutions in a short and efficient manner during COVID, such as covert tracker apps. And having strong surveillance systems in place is very important. For example, we saw that in Portugal, they had just introduced a new surveillance system on influenza before the pandemic hit. During the COVID pandemic, telemedicine consultations were given more priority to decrease the direct contact between the patient and healthcare professionals. Countries published regular, often daily, or even sometimes more frequent epidemiological updates of the situation in their country on dashboards that were set up specifically for COVID, and most reported on daily COVID cases, daily deaths, hospital admissions, and also ICU admissions, and reports were also published. And besides public reports, there were also internal reports and ad hoc requests by policymakers to help with decision making. Data on COVID and its wider impacts was collected through ad hoc surveys that were carried out during the pandemic, or sometimes it was done by adding on modules to existing surveys. So from the assessments, we saw that communication was very important during the pandemic, both between the different stakeholders to organize the response to the pandemic and for the information to flow smoothly. So we saw both formal and informal channels of communication in place. And also another aspect of communication was building strong communication channels with the public, to have regular press bulletins or press briefings to address the public, and the frequency of these briefings changed according to the epidemiological situation. And communication through formal channels with the public was very critical to fight the misinformation and the disinformation around the COVID infodemic. And in Malta, for example, we saw that the health authorities had identified building a good trust relationship with the public as a key priority way before the COVID pandemic hit. So this facilitated the passing on health information to the public during the pandemic. In Ireland, we saw a very good example of robotic process automation, and this was introduced during the pandemic to align data across information systems and to process REB results, notifications, and also for contact tracing data, and this decreased the workload on the human input. And it also performed rigorous data validations and quality checks, which are very important to have accurate data. Another best practice in Ireland was the creation of a COVID-19 data research hub, and this helped to facilitate secondary use of data for researchers. Next slide, please. So we also saw some gaps in different countries, and we can learn from these gaps. So first of all, the legal framework for the operation of COVID surveillance systems was different in the different countries, while in some it was based more on the long-standing established acts that were previously already in the legislation. In other countries, we saw that surveillance systems were operating based on national states of emergency, and this might threaten the data sets and surveillance systems when the state of emergency is terminated. Also, countries have different laws for data sharing, and in some countries it was more difficult to share health data or for it to be used for secondary purposes. We saw that some countries found it difficult to integrate the newly developed systems that they developed for COVID, to integrate them with the surveillance systems that were already in place in the country. And some are still deciding, like on the way forward, how this integration will happen. The pandemic brought with it a very heavy workload in the countries, and finding skilled experts was challenging. And also, some countries also had long bureaucratic processes to recruit new people, so this obviously didn't help to speed up the recruitment processes to get more help with the human resources. For linking health data together, a single unique personal identifier that is common across different data sets is critical, because otherwise it would be very difficult to link the data. And to have a comprehensive picture of the health system in a country, one would need data both from the public and also from the private sector. And unfortunately, we saw some examples where private healthcare providers are not obliged to provide the data. Also, we saw that data collection is a bit weaker in primary or community care settings than in the secondary healthcare. And also, we saw heterogeneous systems being used, and this might be a challenge for data analysis. Next slide. Thank you. So we have learned a lot of lessons from the visits we've done so far. So the importance of a unique single person identifier in the data sets cannot be emphasized enough to be able to link the data. Also, the legislation that can be used together with the health information system elements, it should be highlighted in pandemic preparedness plans. And this should be given due importance, as they have a big influence on the data collection, the processing of data, the sharing, and also for reuse of data. Also, infodemic management should be considered and incorporated in overarching strategies for health information systems. We need a harmonized systems across different health service providers to be able to have a more comprehensive overview of the health service and health system in a country. Systems used for health data should be secure, and attention must be given to analyze any potential security cyber attack threats. So these are some preliminary findings from the PHIRI COVID-19 health information system so far. These assessments will help to generate key recommendations and to lead to more resilient health information systems. I will now pass on the floor to my colleagues from TEHDAS.
Thank you, Marika. So I'll just take over from there to start the presentation on the preliminary findings from TEHDAS. So just as a reminder, as it was mentioned before, TEHDAS is towards a European health data space. So as Linda mentioned, the scope of our country visits has really been to map how the health data management systems are organized in the different countries, how data is used, and all of this looking towards how prepared they are for the future European health data space. So we have 4 slides in our presentation. We start with identifying some best practices from the countries. Then we look at some concerns that were noted during the country visits by stakeholders and needs that need to be met in order to join the European health data space. And then I'll hand over to my colleague Irini for the last 2 slides on what countries expect from the European health data space, and of the 6 countries that we've visited so far, how prepared they are. So just to let you know that we've visited 6 countries. They are Denmark, Belgium, Hungary, the Netherlands, Estonia, and Ireland. And we're going to be visiting another 6 over the course of the next 6 months. So we identified quite a few best practices throughout the countries we've visited so far. So in terms of citizens' engagement, we've seen some really good examples of citizen empowerment and control over their data. So that, for example, in some countries, citizens have a portal where they can access their data, but they can also see who else has accessed their data. And this transparency really increases trust with citizens. Another nice example of citizen engagement that we heard about was an idea of a national level data guardian. So this is an individual who would really act as an ombudsman for citizens. So if they have any concerns about how their health data is being used or handled, they have a direct link that they can go to raise their concerns, also increasing citizen empowerment. Then in terms of the infrastructure, a best practice that we saw is that some countries have really invested in ensuring they have a strong infrastructure for the primary use of data. And then this can be used to further develop into the secondary use. Because I think it was mentioned before, but TEHDAS really does focus, the scope of the project is on the secondary use of health data, so the reuse for any purpose other than the one for which it was originally collected. Then, in terms of accessing and using data, we saw some best practices in the sense that there are certain countries that really perform dedicated support services for researchers and data users, because often one of the barriers that researchers will face is that they may not know where the data is or what data is available, whether the variables that are available will actually answer their research question. So there are a lot of data collections across different countries that we visited who really give support and help them in framing their research question or even identifying the data that they'll be able to use. Another best practice that we saw is that a lot of countries will have platforms. Well, actually, this was from Belgium in particular. We saw a platform which allows interaction between legal officers. So if there are any legal officers who have differing interpretations of the GDPR, they can discuss the issues that they're having and come to joint solutions. Another best practice that we saw was in terms of the legal basis on which research can be done. And that's when countries use the legal basis of public interest for research, which can really improve population health rather than relying on consent. Because when consent is relied on for the reuse of data, it can often act as a barrier to the research if gaining that consent isn't possible. Then finally, the last few best practices that we saw are about the involvement of healthcare professionals, because especially with the secondary use of health data, when you're reusing data that was originally collected for another purpose, and in this case, it's often for care of patients, what is often found is that if the healthcare professionals are really involved from the outset, they're more likely to see the value of inputting data in such a way that it can be reused, so high quality data and structured data. So we saw a few examples where healthcare professionals are really involved in, for example, deploying standards for interoperability, and that can improve the deployment of those. Linked to that is where there were quite a few initiatives across the countries in improving data literacy. So, for example, providing in-person training to healthcare providers on using the IT technology to incentivize them to put it in a structured manner so that it can be further used for research. And then finally, of course, since the European health data space is about cross-border collaboration, it was very promising to see that there's quite a high level of involvement across the different countries in international cooperations. So examples of these are the Beyond 1 Million Genomes project, of course, TEHDAS, BBMRI, and Elixir. Then we did identify some concerns and needs in our country visits. These were both voiced by the stakeholders and also picked up by the assessors. So in terms of the concerns, some countries still do have quite a high dependence on paper-based records, which is not digitalized. Then, as Marika also pointed out earlier, having a single unique personal identifier is really key for being able to link data across different data sources. But we did see in several countries that either the single unique personal identifier doesn't exist at the moment, or it's inconsistently used across the different data sources, or the legal basis for using it can differ. So that was one concern that we came across. Marika also mentioned this one before, is the fact that in some countries there's quite a high dependence on private healthcare, but limited visibility on that sector and limited reporting of the data. And then another concern that was raised is that in certain countries there are practices in place that limit foreign users from accessing their data, which of course when you're thinking about a European health data space is a bit of a concern. And then there is also an inconsistent use of international standards across the different countries. Some countries have quite a strong focus on national standardization rather than using international standards. And then linked to the first point about the dependence on paper-based records, in certain countries there's still quite a high amount of unstructured data. And then finally, in terms of the concerns, another concern noted is that, and this was noted across all country visits, is stakeholders really note that there is an inconsistent interpretation of the GDPR, both across different countries, which can limit cross-country collaboration, but also within countries between different organizations. Then one of the big questions that we're asking during our country visits is the needs that will need to be met in order to join the European health data space. And these on the slide, you can just see some needs that were shared across the countries. So linking to some of the points that we've already mentioned today, there's a need for legal, organizational and semantic interoperability across Europe to allow the European health data space. Most countries identified a need for financial resources, but also for trainings and sharing of best practices at EU level. In the countries where digitalization hasn't been fully achieved yet, there's a need for both EU and local level incentives, but also an enabling environment for digitalization. And all countries noted that the European health data space does need to consider the diversity across Europe and also local sensitivities. And finally, the last point, which was also mentioned by Marika, is there is a need for skilled human resources. And what we heard in our country visits is that's often data analysts or data stewards, cybersecurity experts, and also legal officers who can address the legal issues. So then I will just hand over to my colleague Irini for the last 2 slides.
Thank you very much, Anna. So yes, indeed, in the country visits that we did in TEHDAS, we heard from stakeholders in the different member states about their expectations from the European health data space. So first of all, a country, for example, mentioned how important it is to ensure equal benefits for all countries involved in the European health data space. That means that they all have the equal benefit of using health data for research and policy making. Then some others mentioned that it is very important to also focus on cybersecurity, trust, and citizens' empowerment. And thankfully, when we looked at the legislative proposal that has been published, this is taken into account, and they highlight the need for citizens to have control over their health data and who has access to them. Then, of course, countries expect that the European health data space would enable cross-border research. So by sharing health data and having access for researchers to data from different member states, but also it would also allow international comparisons on certain parameters in case they want to see where they stand in Europe, where their health data management system stands, for example. Another good idea actually that we heard in the country visits, and they would expect it also from the European health data space, is the establishment of a European Health Data Academy. So you've heard from my colleagues the need to have more data literacy, to have data stewards in Europe. And here's an idea that came to create the European Health Data Academy that would provide these trainings to healthcare providers, but also to IT experts or just young professionals on data analysis, statistics, data stewardship, data curation, and all of these new fields that will be important in the European health data space. Then it's very important, and it's expected from the European health data space to have more transparency over the access procedures to health data and over the decisions whether an application procedure was accepted or rejected and what are the reasons for that. That's already also taken into account in the legislation. From what was also mentioned from my colleague Shona, the establishment of a European level platform for legal officers such as DPOs to share best practices, to have working groups where they can explain and clarify how to interpret properly the legislative text. And yeah, so that's something that already exists in Belgium, the DPO Connect, and we would like that to be also done in the European Health Data Space. Another point that was mentioned in the country visits is the development of a manual. So that's a reference document that would provide an overview of the different national health data management systems in Europe. That would help researchers when they want to access data in a different member state to know, for example, in what data collections exist there, also what are the national legislation that are in place, what standards do they use in their health data storage in order to organize how they would analyze the data there. So this is just a reference document that could be provided by the European Health Data Space. Another expectation is that, and this is key, of course, is that the European Health Data Space must be relevant for citizens and health service providers, and it should demonstrate clear and tangible benefits for both. Next slide, please. Okay, so now I would like to show you a bit of a preview of our results from the country visits. And so for this, we have put in this slide the key prerequisites that we think are important to join the European Health Data Space. And these are 8 on the slide. And basically, I'm going to present you a bit the state of play in Europe, in the countries that we have visited at least, in terms of these key prerequisites to join the European Health Data Space. So first of all, it's very hopeful, and I'm very happy to see that in all countries that we have visited, there is political will to join the European Health Data Space. There are discussions going on, and all member states are getting ready to set up the different bodies that are needed to join the European Health Data Space. So political will is there. That's good. Then, as we've seen in the legislative proposal, there is a need to create and establish the national contact point. Unfortunately, at the moment, there's only 1 out of 6 countries that have a national contact point already established, but there are discussions in the member states figuring out which institute will take the role of a national contact point. And now we're talking about the European Health Data Space for secondary use, so to not mix up with the primary use. Then a key component to be part of the European Health Data Space, of course, is to have digitalized data. So to have the health data registered in a digitalized way, in an electronic way, and not be dependent on paper-based health data. This, thankfully, in 5 out of the 6 countries, they use mostly health data that are in a digital form. Another key point is the metadata catalog. So this would improve findability. So the researcher would have the possibility to know what data collections exist in the different European member states, and where can they access the data and how can they access the data. So 3 out of the 6 countries that we have visited are at the moment working on having a common national metadata catalog describing the different data collections that exist in the country. And then another very important aspect that was mentioned also by my colleague Marika is the usage of a unique personal identifier for health. Many countries, many member states have a unique personal identifier already, but some don't use it for health. And thankfully, in the 5 out of the 6 countries that we have visited, they do use a unique personal identifier for health. This is important when you want to link individual level data and make studies that need linkage of health data from different data collections, for example. Then we have also asked questions about whether they have a remote secure processing environment in order for researchers to be able to analyze health data in a secure way without having to download personal level data in their own server. And 3 out of 6 countries are already using secure processing environments. So this is very promising because indeed in the legislative proposal, it's mentioned that this is how the analysis is going to happen in the European Health Data Space using the secure processing environments. in order to preserve the privacy of the data. Then, of course, a big aspect that has been discussed many times and is very important is interoperability. More specifically, here we talk about semantic interoperability, to have structured data using internationally recognized standards. So unfortunately, at the moment, there's only 1 out of the 6 countries that we have visited that has all the health data in a structured format using international standards. And hence they're interoperable. So different data collections they can share their health data amongst different institutes, but also amongst different countries. However, of course, there is ongoing work in semantic interoperability, and this is the topic that will require, I think, a lot of efforts in the European health data space. Finally, I would like to mention the equal access for national and foreign researchers. So thankfully, 5 out of the 6 countries that we have visited do give equal access. So the access procedure to health data is the same between national and foreign researchers. Next slide, please. Okay, so now we completed a bit the presentation of our results from both the PHIRI country visits and the TEHDAS country visits. And here I would like to invite you to our general midterm meeting that will happen on June 23rd from 10 to 12. So in this meeting, we're going to present you the results more analyzed for TEHDAS, for example, per country for the 6 first countries that we have visited already. That's why we call it midterm, because we have 6 more to go. That will be the title of this event is the Mapping Health Information Systems for COVID-19 and a Future European Health Data Space. And yes, that's it from my side. Back to Nienke.
Thank you so much, Irini and Shona, to present the preliminary findings of the country visits in TEHDAS, and thank you, Marika, for the ones in PHIRI. Shona, if you could stop sharing the slides. I see that there is some questions also in the chat, so I think it would be nice to start addressing these. So we have been talking about the methodology, nicely lined out by Linda, and I think there's a question now coming in from Persephone about the shared understanding of the health information system. Let me see if I can stage everyone. Okay. So I was wondering whether the answer might differ for the TEHDAS project and for the PHIRI project. So I think what we found for now in the TEHDAS project is that so health information, the data and information that is needed to monitor the health of the patients as well as the general population, I think everybody agrees on some things. That data should be available in a timely manner, should be trustworthy, data and information should be shared across European borders, and data and indicators should be interoperable. And of course, the communication and knowledge translation aspects are very, very important. So in the PHIRI visits, we saw the PHIRI focusing on the COVID-19 health information systems. We saw that the way this was organized was different between countries. So really depending on the systems that have been already set up, the use of the unique identifiers that is used in the different health systems, and also the legislation that was in place. So for example, in some countries, they operated under emergency legislation. In other countries, a more general public health act allowed for setting up these systems and measures needed to accommodate COVID-19. So there was more difference in the way it was organized than everybody agreed on the same definition of a health information system. But I was wondering, perhaps the TEHDAS team could share some thoughts on this.
Yeah, I can jump in maybe here. So with regards to what we found in our TEHDAS country visits, it's important to note that really our focus was on the secondary use and the sharing of health data across the different stakeholders in the country. So with regards to whether there is a shared understanding what a health information system overall is, and if it exists, I think there is an understanding. But what I think was varying in between the countries is whether, so for us, it was really to focus on what data exists, how you can access this data. So I think there was a bit more variation in the understanding of the different stakeholders, whether they're data holders or data users, where to find which data that they would need, whether for research or policy making. So that was a little bit more difficult with regards to what access procedures are needed to get to these different data collections that are existing in this country. I don't know if my colleagues want to fill in anything. If not, Nienke, I can jump to the second part maybe of the question. So if I'm not mistaken, the consequences of the diversion and how well have you succeeded in engaging stakeholders that are other from the healthcare. So I can say from our experience in TEHDAS, thanks to our really great country contacts who made a lot of efforts to bring in a lot of different views and different stakeholders, we were able to talk to a lot of different aspects. So it was not only healthcare professionals or national public health institutes. We were able to talk to industry, for example, as well. In some cases, we talked to standardization institutes, so that's standards across different sectors. We did then focus more questions on the health aspect, but it was really interesting to see how they relate to the whole aspect of the secondary use of health data. We talked, for example, also to different advocacy group for industry and businesses, because in the end, our focus was to go towards the preparation of the EHDS. And I think a lot of stakeholders in all countries have a stake in it in the end. So this is why it was very important to us to get a very good overview of different views of different stakeholders. And it was very interesting to hear these different views. And hopefully we'll manage to summarize them well in our one-pagers, and then it would be available for everyone to see.
Thank you, Linda. Yes, what is really important here is, of course, that we're not only a health information system is not only focusing on healthcare elements, it's focusing on also other aspects of health. So not only the patients of today, but also the patients of tomorrow. And I think these are also important aspects to take into account when you look for key stakeholders in the country. Maybe an example from COVID-19. So when you think about COVID-19 and the health information system concerning COVID-19, you immediately think about hospitalizations, mortality, morbidity, etc. However, population health goes far beyond these aspects of mortality and morbidity, looking at the wider effects of the whole COVID-19 crisis on the health and the well-being, of course, of the whole population, for which you would need more information, more health information than just healthcare. And also a more general view of the general health of the population and employment numbers, general status of mental health in the population, which you can get from example GP visits, reimbursements, or even health surveys, for example. So these also have to take into account when you select these different stakeholders from the countries. And fortunately, we were blessed, I think, both in both projects with great contact points in each country, who really helped us line up all the stakeholders that we would need to interview, ranging from the ministries of health and research to universities, hospital groups, other IT infrastructures that are governing different health data. And so we were really lucky. And I think this is also maybe the time, because I see in the attendees list, there are actually many of the stakeholders that we have interviewed are present today. So let me also thank them for their cooperation and their time that they have spent with us in order to provide us with all the information so we could create our one-pagers and our reports. Are there any other questions? Feel free to put them in the chat or, of course, raise your hands. I see a question from Zoltan for the TEHDAS team. Where can one find the country visit plan for TEHDAS?
So if you go on the TEHDAS website and work package 4, so in the packages, then you can see the one-pager that we have for the country visits. And normally there should be the list of the countries that we're going to visit. But we can also put it in the chat here so that you know exactly.
Thank you, Rini. I think indeed we will combine all the information that we have presented today together with all the different information fact sheets that we have made for the country visits in both projects. And we will make sure that you will receive them. Either you can download them from our websites, or we can circulate them amongst all the participants. Okay, indeed, Persephone, thanks us for our commentary. Well, thank you so much for the very interesting question. If you have more questions, please feel free to reach out to PHIRI or TEHDAS. I hope that one of my colleagues can put the contact information in the chat so you can copy if you have any more questions. And of course, I would like to direct your attention to the June 23rd meeting that we're organizing, where we go more in depth about the recommendations, the lessons learned, and the best practices of each country with regard to their COVID-19 system or their readiness for the European health data space for each of the countries that we have been visiting then so far. So I would like to invite you all to put that in your calendars, and I will hope to see you in June 23rd. For now, I don't see any more questions in the chat or hands raised. Thank you all so much for your attention this last hour. I hope we really could have tell you a little bit about the methodology that we're using, because that is, I think, a very important tool that you can use in order to get all the information that you need in order to map the health information systems in the different countries. And we're looking forward to see you either in the future country visit we are planning or later in June on our general meeting. Thank you all so much for your attention, and have a great weekend.